I didn't introduce myself. My name's Joel Shepard. I'm the marketing director at PEHP. And we've got Chet Loftus, our director, here today. He'll be doing the presentation. And then we'll be here to answer questions afterwards. If you have individual situations that you want to discuss, we can help you with those. Those of you online, we can chat with you in a private way online, so you can send any questions you have in the chat, and we can talk to you privately through the chat. We've got Taylor Hooton here as well, so she'll be answering questions online. And with that, I'll turn it over to Chet.
I have to figure out whether I need my glasses or not. I might need my glasses to see everybody.
Thanks.
Hey, thanks for being here. Just means the world that you take some time this morning to come and meet with us today. I'm going to give you a little bit of a kind of a real brief update on things that are going on at PEHP. If you've got questions as we go along, just please let me know. And then afterwards, if anybody has any personal questions or situation they'd like to talk about, we'll be here as long as we need to. I'm here. I think Taylor's here, Joel's here, and Augustine's here as well. And so we just appreciate the chance to be here and to again, share some things and also learn from you. I always like these. We do this every year. So far, we've been in Salt Lake County at the city of the county offices there. We've been up at Box Elder County. We've been to Davis County, and now we're here. This is, we're in Taylorsville, just for those that are online. And we're speaking at a state facility. And so I'm going to talk about some things about the state plan that would be kind of unique to the state. And I won't spend a lot of time on that, but I'll just do that because this is a state audience a little bit. Also, probably talk a little bit more broadly too on some issues, just because this is being simulcast, as Joel just mentioned. So I think I want to just start with just telling you how much I love my job. I really feel fortunate. Like, you can't imagine how fortunate I feel to be able to lead PEHP, and I've been doing it for the last 13 years. There's just nothing like PEHP anywhere in the country. I have the opportunity to meet with other folks that are involved in benefits for state employees and other public employees. And there's not a time that I come away thinking to myself, not thinking to myself that the PEHP is a really great thing. And I've only been here for 13 years. I'm turning 60 this year. And so I've worked a lot of different jobs, seen a lot of different things, had a lot of options and opportunities, and I just really appreciate it. And what makes it special for me really is the fact that we are completely and 100% devoted to you and trying to do the best we can for you as public employees. I'm going to be on a panel in about a month or so, speaking to a national audience. And what they've asked me to talk about, along with another panelist, is what states can do to reduce costs in a very challenging environment. The other person that's on the panel, one of the most important things that she wants to make sure that we talk about is how to avoid hidden fees with health insurance plans. Well, I will tell you, when it comes to PEHP, there's no such thing as a hidden fee. Everything we're about is to try to do all we can to preserve your benefits, to make sure that your benefits are being administered under the plan, and to make sure that we're creating new value all the time. We don't care about making money. We don't care about adding costs on. We don't do those kinds of things. We're 100% just focused on you. And I just really enjoy it. It makes my job really easy. I don't have to worry about, venture capitalists telling me how I should be doing my job and how I should be trying to make more money for them. I don't think there's anything wrong with venture capitalists. I've got plenty of friends that work for them. I've got plenty of friends that are those. But at least for me, I'm just really happy. And I just appreciate the opportunity to do this. So PEHP is going through a once in a lifetime, once in a generation type of change. And we probably need to get some more chairs rolling. Make sure we're okay with that. We have PEHP came into existence like in the late 1970s, right? And from that time on, we've had one processing system, one claim system, and we've actually created it on our own. We call it tax, And the reality is the tax is built on the same technology platform as you would see like DOS, or I don't know if any of you guys remember playing Pong when you were like a kid. I played Pong. The only place I could play Pong was at Sears because that's all my family could afford, was to take us to Sears. We'd go there like every once in a while, like on Saturday night, we'd just go play Pong for a little while until the people would tell us it's time to move on or something like that, right? And so we've had this claim system for a long time now, right? Over 40 years. It's really worked pretty well. But the reality is that that technology platform is not going to help us going into the future as much as we need it to be. And more importantly, we have the majority of our staff that is in IT, they are getting close to retirement. And it's really hard to convince people to come in and learn a new computer language that is the only one that there's only 2 organizations in Utah that use this system. We do, and RC Willey, and I think RC Willey is trying to do that differently. So what that's done is it's put us in a position, particularly as senior leadership, to figure out whether or not, or figure out the timing of when we should do this. And honestly, because of my my commitment to you and the organization, which is unwavering, it's the kind of thing that as a good leader, we need to do it now rather than after I go. To delay it any further, not that I'm going anytime soon, but just the nature of this issue is such that is in terms of good leadership, getting the new program up and running was critically important. I will tell you that I wouldn't wish this on my worst enemy. It's been very hard. Luckily for most of our folks that are on with PHP, you're not on the new system. And I don't mean that like luckily you're not on, because it's a great system. It's working just fine, but we've had glitches along the way. And so those that are on the system will understand those glitches, and I'll speak just to those for a minute. The only point that I'm trying to make for this group is that this is just incredibly important for you as those that have their benefits with PHP, and also for PHP in terms of our ability to do that going into the future. So we have been working on this system for more than 5 years, and we have had challenges with the new system. They really kind of fall into 2 primary buckets. The first bucket is what we call data interfaces. And you have our new system, which is called HRP, and this HRP system has to communicate with other systems in this massive ecosystem. You just can't imagine how complex it is between all the providers that are out there, you know, and you know, the pharmacy folks and the state. I mean, the number of connections we have just with the state alone in order to make things work is just really high. So we began 5 years ago. These data interfaces are a little bit like Siri, right? So if you speak and you say something to Siri, and Siri does its best job to translate that information into Google or whatever it's going into, right? And sometimes it gets it right and you're in West Valley, and sometimes it gets wrong and you're in West Jordan, right? It's that kind of issue where we're trying to make sure that the data that's being communicated between one system and the other is perfectly right. And what I can tell you, we've got a really high level of competence on that right now, except it's not enough because we have so many, we've got millions of claims that kind of come through the system, right? So if you've got an error of like 0.5%, that's probably too big. We need to get it down to like, you know, 0.5%. And so right now we continue to work on that issue. We also had some challenges that have largely been resolved with what we would call data mismatching. Data mismatching essentially means that we have a system here that has data in it, and the purpose of that data is to be able to determine whether or not the provider that's coming in is sharing the right kind of data that tells us this is the data, this is a valid data, this is the right provider, this is a valid provider, and you can go ahead and release like $1 million to them. You know, we don't do that lightly. We have to make sure that all the data matches up. I think about it a little bit like a key in a door. And again, if you have 5%, we have about 26,000 providers that are on our directory, right? If you get 5% of those that have a data problem, then the problem is with that is that the claims come in, the claims get stopped until somebody goes in and says, no, this really is a valid provider. And after they figure out it's a valid provider, then they've got to go in and actually get the data from the provider that would bring the data that's coming in with the data that's in the system and matching those up. So I just mentioned this in terms of, again, some of the challenges we've had. About 30% of our business is currently on the new system and 70% is on the old system. It means that we're doing an old system and a new system at the same time. It just means a lot of work, a lot of challenges in terms of just trying to make all those things work together. The claims now are paying within normal range because we've been able to fix the mismatch issue and also some data interfaces issues that are really critical. We were, unfortunately, the system was sending a lot of EOBs. Anytime something like hits your account, you get EOBs, and so some people would get like a lot. We've largely resolved that. The nice thing about the new system is it's paying at 80% of auto pay, and that's really, really good. That means that without anybody having to touch it, the claim comes in, it gets processed and goes right back out. That's good for you. That's good for your provider. we think that's great. We do have some remaining claims that are on the older side, largely again because of this mismatch issue and other complicated issues. And so one of the things that we're working with folks on, both here and otherwise, is if there's anything that's kind of still kind of like somewhere in the haystack, and we're looking for that needle, to make sure that you escalate that to me and other people, and I'll give you my contact information in just a moment. And then the last piece is that we're transitioning membership incrementally still. And so this year, there will be no new groups brought on to the system. It won't be until next year that we'll bring new groups on, which would include the state. So, you know, really a big heavy lift. You just can't imagine how complicated healthcare is. We've done everything we can to make sure the system is within our control. And I love it because I have very little confidence in outside vendors understanding our needs and taking care of what we need. In fact, I would say that our data interface issue is largely due to our reliance on some outside help. And at this point, we've been able to bring all of those functions inside. Now we're consulting more on the basis where we're central and we're looking at other folks, and that's an important thing. And it's a good thing. It's where the system had to go anyway, is us taking over kind of the management of it. I just show this slide just to underscore an important point, and that is that whenever you go to the doctor, even if you've been to the doctor a lot, you know, it never hurts to make sure they've got the right card, right? Show your card. We have two cards because we have two systems, okay? If you are on the new system, which again is 30% of our membership, not including, and the state's not part of that, right? You will have an M number. The provider has to bill the right number. If they bill the wrong number, right, it will ping to the system and the system won't recognize you. So if they thought you had an M number and they tried to do it, it would come back as not covered because two separate systems. So we have 30% in the new system, 70% in the old system, right? So don't worry about anything. It's not a big deal other than just to make sure that the providers have the right cards. When we first got rolling on this, you know, we had to work it through in terms of with providers to make sure they understood this really clearly, that we have two different systems, two different cards. People are going to be on different systems. We had a whole way for them to look up to figure out what system you're on, all that kind of stuff. But again, for this year, no changes for anybody. And there you go. You might have noticed when you go onto our website now that we have, I'm just going to step away. You'll see this on our portal. The purpose of this is to help you to see whether or not you should be on the new portal or what we call the old portal, the classic portal. You know, if you put the name of your employer on there, it'll just kind of tell you, it'll take you to either the new website or the old website. So we have two systems, two cards, right? Two portals. And again, for most people, this is probably new to you. If you're particular with the state, you're probably thinking to yourself, "Whoa, I had no idea this was going on," right? And in all reality, you know, it doesn't affect you, and it won't until we make the switch over. So just to quick summarize, for this year, just keep doing what you're doing. There's nothing new or different on that. For now, if you're on the new system, you've got a new card, you've got your portal, you just keep doing what you're doing. If you're on the old system, you've got your old card, and you've got the old portal, and you're good to go. And then in 2025, if you're on the new system, it stays the same. If you are on the old system, you'll have a new card, and we'll take you, and you'll have to get a new account on the new portal. But
Is that calendar 25?
So the way to think about it is that the 30% of PHP groups that are currently on the new system all came on in January, right? And so the way to think about this is that you won't have to make any change. I really appreciate the question until your plan year starts. So if you're with the state, it's when your deductibles restart and all that kind of stuff. It'll be July. If you're with a school district like Jordan School District or another school district like that, it'll be September. Nobody will be January because all of our Januaries are already on the new system. So when we get to July, that's when we go, and September as well. Okay, for providers, this year's going to be easy, and the next year we're going to have to make sure we get out the word that says, okay, people are moving over, and make sure that you keep in mind, right, you know, that all the way up into the last day of your plan year, you use the old card. And then as soon as you get to the new plan year, use the new card. That difference will be really important because again, two systems, and they're going to process at different times. At one year next year. Any questions about that? Okay. So next issue is a really hard one too, right? Hold times have been really tough the last little bit. We have had a 20% increase in calls over the last year. I think that comes out to something like, Joel gave me this morning and I thought it was really helpful. It's come out to 280 more calls a day or 35 more an hour. So we've had a lot more calls, which means it's been a little tougher to kind of handle those. We've also had a challenge because people tend to call at the same time, right? They like to call midday. And so I will tell you that we've been looking and crunching the numbers to figure out how that rolls, right? It also happens to be the time when usually our people are trying to take lunch. We're trying to figure out now, can you have like a little break and then can you take lunch at like 2:30? Can you hold on till 2:30, right? And so it's been a real challenge for us, right? We're hiring a ton of people. In fact, I would just put a plug in. We are now hiring people part-time. Based on the data we've been looking at, right? We can tell when you call. And so we have like a couple of shifts for part-time workers. One of the shifts is like 9 to 1. The other one is, I think, like maybe 10 to 2 or something like that. Maybe it's 11 to 3. But as you can see, there's overlap in terms of when the most intense times are, which tend to be like 11 o'clock and like at 1 o'clock, type thing, right? What's really fun is that these are completely remote jobs. And so I talked to a class just the other day that was just so fun, right? We had 2 people from Carbon County, which is what we were exactly hoping to do, that we could appeal to folks, take our pool of people that would like to work for us and would like to work on a part-time basis. We've expanding that throughout the whole state if somebody would like to do that, right? The second thing is that we had 2 folks that have retired that decided they'd like to come back and do some work, right? And the 9 to 1 time frame worked just fine for them, or the other one, right? I will tell you that one of the coolest things that we've experienced in this transition, which again, we've been involved in for 5 years and been really hard for all those 5 years, right? I can't tell you how many folks we've had that have retired from PHP that have been willing to come back and help us out, working part-time. And so that's just been a real resource. Invaluable people. They know exactly what's going on. They're just such professionals, just love them. And then we had one person that's decided to work with us part-time that's been at home for something like 17 years that's ready to come back and then they'd like to do it part-time, right? So if you know anybody that would like to do that, that's great. Our part-time thing, we pay them a little bit more because they're usually not benefited. And so we try to be really competitive on that piece. But we're hiring a lot of folks. We're trying to improve our processes. There's a lot of things we're doing in this area. We recognize that this is a huge dissatisfier and it is our #1 responsibility to make sure we're doing things. I will tell you that when people don't want to call is on Mondays or Fridays, particularly early in the day and later in the day. We're putting more information online. We know that a lot of you are, that's your preferred route anyway. And honest to goodness, anything we can do that we can put on there that will help you out as we're kind of dealing with these issues, we're putting it on there. For those of you that work for the state, you have an amazing resource with Eric that can help with questions and issues too, as they may come up. We are putting more things on our website for providers. I will tell you that we've been deficient on some things with respect to the new system that has called providers to have us call us more than we'd like them to. Historically, what we do with providers is we essentially say, if it's on the website, you can get it just as easily as we can pull it up for you because we want to keep our bandwidth open for our members. To the extent that we can't refer them to the website, it means we take their calls in ways that kind of jam things up a little bit. So we're doing everything we can to try to make sure that for providers, they're there so that when you're calling, it's primarily member line rather than provider line. Lastly, our message center, we've got that available. It's a really good way to go, we don't want you waiting on the phones. We don't want any of those kinds of things, right? But if you want to use the message center, that's a great way to be able to communicate with us. And so, I consider myself to be like chief member officer of PHP along with Joel and Josie. Josie runs our service center. So if you're dealing with any kind of like problem that you need my help on, any kind of immediate attention on anything like that, you can email me at managingdirector@php.org, right? And then the best thing you can do is email me and then just send me a text. I've got a lot of email type stuff, right? And I try to stay on top of everything, but I'm always on top of my text. And so if you text me and just say, hey, I just sent you something, I really would appreciate your attention. I'm available that way. You can also reach me on the message center. I try to stay on top of that. I'm not perfect on that one by any stretch. Sometimes, unfortunately, I'll get to the Friday when everybody else has gone home. And I think to myself, oh my gosh, I don't think I've looked at my message center. And then I go and then I kind of frustrated because I can't work on every issue that I need help on, right? It just frustrates me. But email and text is really good. And message center, of course, is available as well. So I just wanted to take a really quick minute or two. I know that this is only going to apply to folks on the state. And so, so just bear with me for just a second. So this year, for the STAR plan only, okay? So for the state, there's the traditional plan, which is where you have copays. There's the STAR plan, which is an HSA plan, and it has a $1,500 deductible or a $3,000 deductible for either singles and / or couples, families, right? And then we have something called Consumer Plus, which is a super duper high deductible health plan. This change only deals with the HSA plan, the STAR plan, right? And so we've done two things this year on the STAR plan. We've done a couple things on the STAR plan. So the first thing is that the deductible has had to go up by $100 from $1,500 to $1,600 for singles, and from $3,000 to $3,200 for couples and families. And this is because of federal law. Federal law requires that to be HSA qualified, that you have to meet whatever the minimum deductible is. If you're on the HSA plan, this should say something nice to you, that you have the lowest deductible allowed by law. Lowest deductible allowed by law. And it used to be $1,500 and $3,000, and now it's $1,600 and $3,200. Okay. The next thing is that we have taken the out-of-pocket maximum. Now, if anybody asks you what's the most important thing you can look for in a health plan, it's your out-of-pocket max. It represents the most you will ever have to pay out of pocket in a year. I will tell you that for all these years, the people on a traditional plan have had a significant advantage, a great benefit, because they have, for a long time now, they've had a $3,000 maximum for single, $6,000 for a couple, $9,000 for a family, but they've had what we call an embedded individual maximum out of pocket, right? So this last year, what we did is we lined those together. It makes it easier for you to compare and choose, and honest to goodness, the embedded individual maximum out of pocket is just a really great benefit. What does it mean? It means this: if you have any one member of your family who has $4,000 in expenses in a year, you stop paying after that. You hit 4,000 and you're done. Right now, if you're on a family plan, you'd have to go up to 7,500 for everybody, right? This way, we're looking at 4,000 for an individual. Take it to step two. Let's say you have two members of the family that have had really high costs. You'd have 4,000 for one, 4,000 for the other. You would max out at 8,000, which is $500 more than currently at 7,500 bucks, right? But you had two members that you could do the maximum on, right? So the good news on this is that it aligns both the traditional plan and the STAR plan in terms of how maximum out of pocket works. It provides a really good benefit for those that have been on the STAR plan. I know a lot of people that they've always wanted to go on the STAR plan, but have never have, because they've had one member of the family that is really high cost. And this helps out in those situations. The good news is it doesn't matter what the health condition is of a person. Doesn't matter. If anybody hits $4,000 because of an accident, because of a surgery, because they're on high cost drugs, whatever the situation is, they would benefit from that. The only other thing I would add is that because the deductible went up and the maximum out of pocket went up a little bit for people that are singles on the STAR plan, we've taken what we call the actual value of that, and we've put a little extra money in their HSA. Just because for them, they already have an embedded max amount of pocket. They wouldn't get the benefit of that otherwise. So I think it's really, really good. I'm glad we were able to do that this year. Second thing, very quickly on the state. This is, again, the state only. There will be a premium differential between the Advantage Network and the Summit Network this year, and we'll just see how things roll. But this reflects the fact that the prices, when you look at this whole bundle of goods for the Advantage Network versus this whole bundle of goods for the Summit Network, the Advantage Network is a little bit more expensive than the Summit Network. And so it makes sense that those that are purchasing a lower cost product would get a little bit of a discount. It also makes sense for the hospitals that we work with that are giving us, and the doctors that are giving us a little bit better deal. They also have the benefit of providing that, right? The good news is that the difference for you is really pretty marginal. The way to think about it is you think about the traditional plan. If you're on the traditional plan for the state pays 92% of your premium and you pay 8% of your premium, okay? 92 and 8, right? With this change, what'll happen is that rather than paying 8% as the patient now, as the members, what we call you, if you're on the Advantage Network, you'll pay 9% of the premium, 1% more. If you're on the Summit plan, you'll pay 2% less than you did last year as a percentage of premium, right? So there's a 3% spread, but for people on the Advantage Network, it's 1% more. Hopefully, it's not a big deal. And instead, we've got 2% less. So it's 9% and 6%, and that's what this reflects. The last thing I just wanted to share, and again, this is for the first issue is not so much for the state only, but I'll mention that for just a second. One of the real advantages of being on the state plan, and PHP-URS is also on the state plan, and Weber State is, and so it's more than just the state, right? We've got a total of about 74,000 people that are on it, is that the state often will pilot test benefits to determine whether or not other folks should have to do this. It's part of the political process. Somebody will come to the legislature. They did this with autism years ago and said autism should be covered in the state. It wasn't being covered by anybody in the state. And the state was the first to say, yeah, let's do autism. We'll do it as a pilot, see what it's like. We'll give this benefit to state employees, and they're maybe the only ones in the market that are getting it, right? And then we'll test it and we'll see what happens. With autism, we did it for a couple of years, got some experience back from PHP. The legislature felt comfortable enough that they said to the rest of the market, we think you should be covering autism too. So the state often is the place where you test a benefit, see what it costs, see what it's like, and then they kind of spread it. One benefit that we've been providing for a little while under a pilot program is an IVF benefit, in vitro fertilization, right? And bottom line is that we learned as a result of doing work for the state that this was a really important benefit for the state to offer, because a lot of people are getting IVF pregnancies and births. And the problem is when they were doing that, the state was paying for all the complications related to those births. And the complications were coming for two reasons. The first reason is that when people were paying out of pocket to implant embryos, they would want to put as many in as they could. And anytime you have multiple births with IVF, the complications skyrocket. The other thing we found was that when folks were having IVF done when they were older women, that the maternal health could be a real factor in terms of complications. So what we do now is that every time somebody has a single embryo implanted, we'll pay them $4,000, right? And it doesn't help a lot because maybe it's $16,000 for the initial, harvesting and that kind of stuff that happens at the beginning. But if you harvest quite a few eggs and embryos, right, and then you implant them one at a time in different cycles, that $4,000 really helps. And so we've done that and said, listen, the only way you get that $4,000 is if you do single embryo implant, and then you do it when you're under 40, at least for the harvesting part. And so this is something we work with the state on. We think this is a great benefit. We know this is great for maternal health and for the kids that are born and everything else, that we can do it in a more healthy way, in a supportive way. We now offer this benefit to all of our employers. Most of them have accepted. I think there's some that haven't. So it's something you'd have to look at your own employer if that's not you. But I just want to emphasize again, since this is a state audience, at least location wise, that you get enhanced benefits like this, at least before others do. We are currently, this again is for state only, we're covering doulas, which are essentially maternity coaches. And we also have birthing centers, which applies more across the board. We have other things that are enhanced benefits for state employees, reproductive preservation services. We've got kids meaning like 18, 19, 20, 21, 22, 23, 24, whatever it might be. Maybe it's up to 40 that are going to undergo some form of chemotherapy that might make them sterile. And so we have a program based on legislation that came through to pay for preservation of for reproductive issues like sperm and egg and those kinds of things. The other thing that we continue to have and have had for some time, which is a benefit limited to the state, is bariatric surgery. And that's been something that's been around for as long as I've been around, for about 13 years now. Okay. So some good news. We have been able to negotiate a contract that's allowed us to do what we wanted to do forever and ever, and that is to make insulin, fast-acting insulin, free to all of our members, regardless of what plan you're on. This is a huge win for you, and it's a huge win for us. In addition to this, we are able now to provide test strips and long-acting insulin before the deductible for a $10 copay. This is really important, right? Because when you think about a deductible, right? Again, if you're on an HSA plan, usually you have to pay $3,000 before the health plan does anything. If it's before the deductible, it means it's like preventative, where you can get this before you do your $3,000. So you don't have to do $3,000 for test strips, and for long-acting insulin, if you need that, it's $10 when you go. Again, we're really excited about this. GLP-1 coverage, just so you know, we do cover it for diabetes in certain circumstances. This stuff is really new. It's the longitudinal data is very unknown at this point. The fact that it is chronic medication is like a big deal. The fact that you have to take it for your life, and then if you come off of it, it can be a challenge. At least those are the indications right now. We currently do not cover it for weight loss. That's for a lot of different reasons. Again, the fact that you have to keep taking it and all those other kinds of things. And again, not knowing exactly what the long-term impact looks like. The other issue, quite frankly, is that it's $14,000 a year. At $14,000 a year, if we covered it as your health plan, it would essentially take your current pharmacy cost and essentially triple those. And the total cost of the plan would probably be close to about $4,000. So the amount of money just to cover this one drug would cost about that much. So, we're all hopeful that we'll get to a better place to the extent that this can be a real helpful thing for people long-term. But again, trying to get more information on long-term impact and then kind of trying to balance things out is kind of where we're at today. Just want to roll through this for you. This is kind of a big deal, and I just can't underscore it enough. Historically, if you went to an out-of-network hospital due to an emergency, you could be in trouble. Now, PHP, from the day that I came in, and this was my number one priority, and that was to make sure that if you went to an out-of-network hospital in Utah, that you would never be balance billed, right? So I found something out the other day, right? When you look at out-of-network, if you look at hospitals outside of Utah, when they bill people, right, for their services, they charge, their billed amount is 593% of Medicare. So if Medicare would pay $1,000 for something, right, and they accept $1,000, right, when you go to an out-of-network hospital or out-of-state hospital, they would bill you close to 600%. So rather than 1,000, they would charge you 6,000. Generally speaking, when we get contracts, the contracts are usually probably between 200 or 300%, right? But the problem is that the way out-of-network used to work outside the state is that if you went to those out-of-network hospitals, it's possible they could try to charge you 6,000. We might pay, or 600%. We might pay 300%, and they might come after you for that additional 300%. It's just a mess. It's like the worst. Again, we fixed it here in Utah. We had broad networks in out of state to deal with this issue. Guess what? You don't have to worry about it anymore. You don't have to worry about it anymore. If you have an emergency, you can go to any hospital anywhere in the United States. Better yet, you can go to any hospital in the world. When it comes to going to any hospital for an emergency in the world, we always pay what they bill outside of the United States. Why? Because they're always cheaper than the United States. Always, without question. Cheap. Please.
Documentation would you need when you go
Yeah.
out of the country?
Yeah, you just give us whatever you showed that you were charged, that you paid, or whatever the case is. A lot of times you can kind of pay out of pocket, even going to the emergency room type thing, right? But it would just be, whatever documentation they give that would show us that you in fact had an emergency and those kinds of things. And then you just send it to us and we take care of it. And so right now what happens is you go to that hospital, that out-of-state hospital, right? In network or network, it doesn't matter. You will just pay whatever you normally pay. And you don't have to worry about it. We'll pay what we normally pay. And what happens then is that if the hospital or the doctor is really mad and they think we haven't paid enough, they can take us to arbitration. They will make a bid at arbitration. We'll make a bid at arbitration. The arbitrator it's called baseball arbitration. They have to pick one or the other. They can't do anything in the middle. No splitting the baby. So if we say it should be 300% of Medicare, and they say it should be 600% of Medicare, we present that to the arbitrator, and the arbitrator will pick one or the other. So it's been a little bit more challenging for us to work through this stuff in terms of figuring out how things work outside of Utah and all that kind of deal. But the good news is you don't have to worry about it anymore. One other thing, just so you know, this is kind of important as well. Everything I've talked about right now is an emergency, right? Emergency, right? Got emergency, just go to the hospital, right? In a non-emergency situation, right? You want to go to an in-network hospital. And the good news now is when you go to that in-network hospital, if there's an out-of-network doc, like a radiologist or like an anesthesiologist or somebody like that, you didn't even you saw them, right? Or like an ER doc. This really helps with ER docs. There are places in America where ER docs would not contract with health plans just so they could balance bill you because they want to get the 600% rather than the 300%, right? If you go to an in-network hospital, just regular, you're protected from these kind of doctors. I think there's a question.
So is that information available on the website?
Yeah, for sure. Okay. The last thing I would just say, since we're here, is we do have a directory for out of state. And so if you have a family member that lives out of state, whether they're going to college or something like that, we have providers there. Use that directory, and it'll give you the services that you need that way. Okay. Just talking a little bit about providers, our provider panel continues to grow. We've gone from 20,289 to 22,090, which, it's about 2,000 difference. Our dental network has continued to grow as well. We've gone from 1871 to 1952. We think this is an important part of our responsibility to you to provide as many contracted providers as we can. Because again, when you go to a contracted provider, they have to take our rates. They don't charge you that 600%. And we try to do really good. We don't like 300%. We like 250 better than 300. We like 200 better than 250. We like 150 better than 200. If we can get it to Medicare, which we actually do in places, at 100%, we like that the best. Next thing I just wanted to take a moment on is mental health and services here. Steve Ellison is a legislator in Salt Lake Valley who has single-handedly taken on an issue from almost start to finish in a way that I haven't seen in my 30 years on the Hill. And the specific issue that he's taken on is creating an infrastructure for people that are dealing with a mental health crisis. Historically, you would just call 911 or you would go in an ambulance, they'd take you to the hospital. The hospital would kind of just try to figure out, do you need inpatient or can you go home? And if inpatient, they just kind of transfer you over, but not a lot of care delivered in the ER. That's not their role. Their role is to stabilize, right? So it's really cool. And actually it was Daniel Thatcher, who's probably he may be the senator who represents this area. Senator Thatcher was the one who really pushed this global number, 988, that has since, because of our congressional delegation, has become a national number. So if you're ever experiencing any kind of mental health related issue or know anybody it is, 988 is the number, 988, 988, right? When you call 988, it will connect you into the service that you need, right? And so we have things called mobile crisis units that are a little bit like an ambulance. That's the closest thing you would think it would be similar to, right? And what happens in that situation is that they will come out, not make a big deal, stay with the person, see if they're okay to be at home, see if they need to go somewhere else, whether it's inpatient or to a receiving center. But it's all on the ground, professionals, they know what they're doing, trying to help folks in that situation to get them to the right place and get them the care that they need, right? And as part of that, they can take them to receiving centers. Receiving centers are essentially the equivalent of ER. Somebody will be there for maybe about 24 hours, right? But the purpose there isn't stabilization. It is to really help the person deal with the crisis rather than just evaluate the crisis. Huge difference, big deal. And so I would just underscore that. You know, I think at one time or another, probably every family may have some moment like this. And anyway, just want to share that. The next thing I want to share is psychiatric services. They're impossible to get not only in Utah, but anywhere else. There's just an absolute crisis. I've got a daughter who's a PA, and when she was telling me she wanted to be a PA, and she said, "What should I do?" I said, "Okay, you only have two choices, rheumatology or psych." We can't get enough of either one of those, right? In fact, she went the psych route. When she came back, she moved back to Utah, she couldn't find a job as a PA because there weren't any psychiatrists to work for her. Because as a PA, it means she's a physician assistant, right? Just tells you, right? So what we've done is we've been looking high and low for some time to find a solution to this. The solution we found is an online telemedicine, telepsychiatry solution. Right now, you'd be really happy if you could get in to see a psychiatrist on an expedited basis in 2 months. Under our contract and under our relationship with this group called Brightside, we can get somebody in within 48 hours. So much better. The next thing I would just want to highlight for just a second off this slide is counseling. Under counseling, EAP. This means Employee Assistance Program. This is an incredibly important benefit that almost every employer has. You'd have to talk to your employer for sure. The state uses Blomquist, I know that part. Their job is to just help you with whatever you may be going through that may be difficult. You know, my sister's first husband just died a week ago at the age of 51. Absolute shock to everybody. They've remained close for all these years. They share 3 kids together. I will tell you, it's been an incredibly difficult week. Blomquist Tail is exactly the kind of resource that is tailor-made for this kind of situation. Nobody knows what it's like to lose a spouse or to lose a parent, especially at that age. Hopefully none of us experience that, and those of us that do know how hard that can be. EAP is designed with that in mind, to really help in those crisis situations where you just need somebody to be able to talk to, right? So that's available as well. We have mental health counseling that we do as well through PHP. It's just a regular member benefit. The nice thing about EAP is you never have to pay anything out of pocket. You go through the health plan route, you know, it's just the normal stuff like that. Okay, so this is just a slide that helps you see a little bit more about Brightside. Please.
Do you show which mental health counselors, like, they know sign language? Do you
I
have
think
sort of
so.
that language?
I think so. And if not, if you'll send me an email or a text, I will double check and get back to you personally on that.
Okay.
I believe we do, though. We have like a place for all the languages, and I think that would include that sign language as well.
Okay.
Okay, so this is a slide that just tells you about Brightside. And again, it's a telepsychiatry service. It provides both speed and convenience. We have another provider that we've done some work with that we're excited about. It's called PEHP Care. PEHP Care doesn't have an actual clinic or a building. What PEHP Care does is they do everything online, or they come to your house. We think that they're a really good option for folks that might be homebound, for folks that may have other kinds of challenges. Really good for chronic care. And not only because they're really more digitally based than anything else, they provide more service that are digital that we think can be really helpful for folks that have unique healthcare needs. In addition, we've been doing a lot of work with a group called Noble Health. we've fully gotten in the business of parenting, coaching and parenting support. You know, it's really challenging. And as parents, I know I've had quite a few kids that are all 24 or older now, you know, so it's great. I've got grandkids that are teens, and that's great. But, you know, this is a really good service, and we offer it digitally, and it's coaching, and it's all this other kind of stuff. It really helps in those more, you know, challenging and less challenging situations. Again, everything we try to do with this is we try to provide basic information, just helpful stuff, all the way up through kind of coaching and those kinds of things, right? But we think this is a really great way. We found over the years that when we provide behavioral health assistance, particularly to younger people and families, that pay some real benefits to everybody. The other thing I would say is that we're looking at taking this model and partnering with FIA and with others for things like diabetes. So again, a lot of digital app-based things, a lot of interactive things, a lot of you can contact and chat and contact, you know, all those kinds of things. But we really do think healthcare should be going more into a digital space, and we think that they would that'd be great for us to be able to provide those kinds of things. Quickly on just the last few things. Preventative care is really an important part of the plan. Again, these are things that you can receive without having to pay anything out of pocket. If there's one complaint that we see all the time on this, it is when you go into the doctor and the doctor does more than preventative care. They do something that would come in outside of the preventative care bucket and goes into the treatment bucket. The preventative care bucket is described in federal law. Federal law is really, really strict when it comes to HSAs. They want it to really be high deductible health plans, right? That's what they want. They want you to have to pay your deductible before you get benefits, unless it's preventative. So if this is a real concern for you, because it can be, right? Because you can go through thinking, you know, you don't want to pay, you know, you're not looking to pay anything out of pocket. You know, you just want it to kind of just be preventative. The best thing you can do is just talk to the provider and make sure that they understand it's just a preventative visit. And if it's going to be something different, to let you know. We have a lot of wellness programs. We continue to try to innovate and have fun with these things. One of the things we've done this last year that's been really good is that we've added another engagement rebate for our Medicare members. They currently have you know, kind of we call it the age well rebates. And again, what we focus on is engagement. We want you to engage, right? Engaging with our programs, engaging in healthy behaviors and all those other kinds of stuff, right? And so when you do that, then we have rebates, we pay for that. We also do things for weight loss, and we do things for diabetes and all those other kinds of things, again, as you engage. You know, this is an important part of what we try to do. I don't think I'll say very much about this. This is just, again, to do a little bit of review of maybe some things about a health plan in terms of how it works, right? And the only part that I would just kind of underscore for a minute, I guess, is, again, when you think about your deductible, that's the part you pay 100%. And then when you get to what we call cost sharing or co-insurance, that's what when you share, you know, we'll pay 80% as the plan, you pay 20%. When you hit your max amount of packet, that's when the plan pays 100%. And then preventive, of course, is 100%. If you're on the traditional plan, you have co-pays that come before the deductible. And so that's a little bit of a difference. Just in terms of networks, we have two primary networks in Utah. One is the Advantage Network, which is largely Intermountain Healthcare and their hospitals. A lot of other doctors that are not employed by Intermountain, but the hospitals are largely Intermountain. And so you've got integration, maybe a little bit more on that system. And then the Summit is, you know, Holy Cross, we call it more Common Spirit now, the University, Mountain Star. There's also a lot of freestanding facilities there. Intermountain actually recently has started having more freestanding surgical centers, which are lower cost than going to the hospital. The Summit has surgical centers as well. And because they have these surgical centers and freestanding imaging centers, they have more cashback opportunities and more what we'll call copay opportunities. just to kind of give you a feel for, where you go matters. Again, our number one objective is to help you preserve benefits, right? For as long as I've been at PHP, and I'm not saying it's about me, but I'm just saying in terms of my institutional knowledge, the state has never made their benefits worse for state employees. It's really kind of interesting. Every two or 3 years, the state will do a compensation survey. The compensation survey says that our benefits are always getting better. The reality is they're not getting worse. It's everybody else's that are getting worse. So keeping the benefits really important, right? I think preserving the benefit, it's really good. The amount that you get an HSA is really good. The amount that the traditional plan is really good, right? And so just as a general construct, right? Just a general framework. If you can get something done in the office, that's always going to be good, convenient, less costly, right? Then we have things called freestanding facilities, imaging facilities, and surgical facilities. If you can go there, really good, right? After that, there's outpatient. Outpatient means hospital. As soon as it says patient, you mean hospital. If you go outpatient in a hospital, the costs are significantly higher than they would be at the office or at freestanding. In fact, a really cool secret is if you're on the traditional plan, just think about this, and you can get a procedure done in office, you pay one copay for the whole thing on that. You might do something that would cost thousands of dollars at the hospital. You're going to pay $25 or $35 maybe. And it works, right? So where you go is important. If you can stay out of the ER and go to urgent care, ER is 10 times more expensive than urgent care. It's kind of fun. I was actually driving by and saw like a freestanding ER, right? And just because it's an ER, it would be more than if it was just an urgent care. Okay. Some of the things we're working on in this respect is we're working on our cashback finder, right? We've been doing cashback for a long time. If you go under our cost tools, and I'll show you that in just a second. If you go to lower cost one, we had a bill that was passed a couple of years ago, right, that essentially said PHP has a legal obligation to share savings whenever a member goes to a lower cost provider, right? Within reason, right? I mean, it's got to be like substantial, right? It's not like $3. We're not going to give like you $1 when we save $3, right? So we're working on an app that would allow you to just go onto the app and see where you get cash back. Again, if you're on the Summit network, you can have more opportunities in Advantage network, but you can see. The other thing we're working on, and this would be for just people on the traditional plan. And what it means is when we get this up and running, you'd either get copay if you're on traditional, or if you're on the HSA plan, you would get cash back, right? And cash back again is where we just give you money, right? If you needed a high cost drug, right, we might give you $1,000 for taking one drug over another drug. It's as high as $1,000, right? In this cashback concept, right? You save money, we save money, we give you cash back. The idea with copays is that rather than giving you money back, we take less out of your pocket. So it's possible on the traditional plan that you need an knee surgery done that might cost everything. You'd have to pay $3,000, hit your max amount of pocket, all that kind of stuff, right? There's a chance that that we would be able to let you have that surgery at a surgical center for just $325 out of pocket. And maybe an MRI might be $50. So, so we're working on this to translate everything into either a copay or cashback. And today we have cashback. If you go under our tools, our cashback tools, or our cost tools, you can just see it on our thing there. And you just put something in. This one, I think, is the MRI of the back, if I can see that all right. It tells you that it's $333 if you go to freestanding or a clinic. And it is $1,800 if you go outpatient. I don't know how many of you still recognize what that little green symbol is. So at some point, yeah, it's a phone, right? At some point, it's going to look more like an iPhone, I imagine, than like a home phone. I don't know. Does anybody still have a home phone? I don't know, but we've got that. You push that. What that tells you is there's cash back available anytime you see that, right? With cash back, you just give us a call, say, yeah, I'd like to get cash back, is how we do it today. Going in the future, it'll be you just look at the app. The app will take care of it. So this tells you the part that you need in terms of this comparison. The next thing we give you is we give you places that you can have it. You can go. Again, there's gonna be more opportunities on Summit than Advantage. But these show you some of the providers that you can go to for this back MRI. We do the same thing on prescription drugs. The main purpose of this tool is to allow you to have an informed conversation with your doctor. So again, if you're on the STAR plan and your doctor is giving you a drug that's $100 a month and you're not going to get any help from PHP until you get to $3,000. And in fact, there's a drug that's comparable for $6. And you want to take a look at this and just talk to your doctor about it and say, can you help me? Is it possible for me to have the $6 one? Because 6 is less than 100 and there's a lot of inflation going on today and gas prices are going back up, right? Right? It just lets you have that discussion. If the doctor says, no, you really need this one, awesome. If the doctor says, no, this will work, no problem. The doctors don't have this information, unfortunately. We've talked about how can we get this information in their hands? You know, we'd love to, but they don't know. And so we try to put this in your hands so that if it's important to you, again, you know, our job is to provide tools and help for you. Because again, from our perspective, if it helps you, it's a good thing. If it helps you in your life so that you're not having to pay any more than you have to for healthcare, which is already taking almost 20% of GDP every year and costs $24,000 for every family, we'd like to do that for you. And then if we can keep the cost down for everybody, then we know that we can manage things on the hill when it comes to renewals. What we try to do. I probably won't spend any time on this for time and otherwise, but there are situations, and if you want to talk to me afterwards, where you can go out of network and actually save money compared to in-network. And I'll just say it this way, because this will be good enough. I just showed you an example of $300 versus $1,800, right? If you were before your deductible and you were on the STAR plan and you went to the freestanding one for the $300, we credit every dollar toward your deductible the same. So you get that full $300. So going out of network can be very, very challenging. You don't want to do it like haphazardly, because I just told you, you can get the 600% when we pay 300%, and they may try to sue you for the 600%. Happens every day. I hate it. But the other thing that's happened in the market is there's something called a cash price. If you go ask any kind of provider, what's your cash price? And they give you a cash price and it's within your deductible period and you like that better, go with that provider. You can just send us the bill. We'll take care of it. So just, I don't do that kind of, I do it like live because it's kind of hard to explain and for people not to maybe have challenges with that. Okay. And I'm good.
Yeah.
Please.
I've been seeing some standalone clinics that offer like a direct pay subscription based kind of
Yes.
thing.
Yeah.
Is that what you're referring to in that case?
Let's talk about, so from here, if I'll go ahead and answer this question, and then we're going to be here for as long as anybody would like to talk to us about anything else. But thank you for being here and thanks for what you do. We love what we do because of who we serve, because we know who you serve. And I just want to thank you for all you do. And like I said, I just love my job and it's all because of who I do it for.